are very happy to moderate this session this morning. And the topic has been expressed, and we have the best presenters for the day. We shall start with the only woman in the house, on the panel. Kairangwa is a nurse by background, a public health expert, a leader in the pragmatic implementation, and as you've heard, she heads a very important partner organization called JPIEGO. You are most welcome. We have Dr. Anup Kumar, who is the Clinical Support Services Director at Erecta, and he has been in the field for quite some time, 31 years, though he looks much younger than that. And anything to do with the gamma knife and the treatment of cancers, he's the man we are going to look at. Noam was here yesterday. He's going to tell us much more in terms of creation, innovation, and the creation of these technologies in as far as advancing our theme and sub-themes of the day. He has held a number of portfolios, as you heard, and he's a vice president at this organization today. The other presenter, panelist, note that he hasn't been mentioned among the first, is Professor Abasi, a highly accomplished radiologist consultant, and looking young as he is, he has 16 years of experience as a senior radiologist, and you're most welcome, sir. We have Mugumya Silver, who is a senior digital health business analyst for Rwanda Ministry of Health, and he's an expert and a leader in the implementation of Rwanda Healthcare digital transformation strategy. We have Brian De Francesca. I think he does not need much introduction. We had him yesterday, and I cannot add more because if I do, I risk misrepresenting him. We are going to, as Dr. Ndoli indicated, our sub-theme today is innovation and intervention as mitigation measures to conquering cancer, and in the fulfillment of our theme, how do we bridge the gaps in innovation, in interventions that we need, through education, training, and improvement of care. So we can start with Professor Abbas, and they can push the slides for you. You can talk while seated, or you can come and sit here. No big deal. Yeah, sure. Can we have the slides pushed, please? Number 6.
Yeah, he knows he's mixed orders.
Okay.
Good morning. Yeah, and we need the clicker also.
There was a slide pusher is there, yeah.
Here we go. Good morning. My name is Dr. Ahmed Abbasi. I'm a professor of radiology at Cairo University. I'm also radiology AI consultant for Paxera and radiology AI team lead for a company called Newsoma, also based in the US. Okay, this is the hospital that I work for. It's called Cairo University Hospital. It's one of the biggest hospitals in the public sector in Egypt. I started my residency program in 2006. I was very excited, of course, starting as a new doctor. When I went in, I told them, okay, show me where I'm going to take the CT-guided biopsies. Where am I going to write the reports? And he told me, no. First of all, you go to a place called the Joint Reporting Room. So basically, the Joint Reporting Room is a room where all the radiologists in the department, all the consultants, they start writing the reports on seeing the CT scans on the illuminator, and then they write the radiology reports in handwriting, and then all these reports go to a joint room where we, as junior doctors or junior residents, we have to revise the spelling and make sure that the typist puts it correctly on the computer. So this process from the time the patient does the CT or MRI till he gets the report takes around from 6 to 9 days. We have no shortage of CTs and MRIs in Egypt, but the process to me did not make sense. So I went and spoke to the head of department, and I told him, this is crazy. We have to do something about it. He said, okay, what can you do? I told him, I'm very good at computers, so I can do this for you. So this is my first published paper. It's in 2011. It's called An Economic Approach for Development of Picture Archiving and Communication System, or PACS, in teleradiology and Asr Aini Radiology Department. I did all the wiring. I just measured all the wires and saw how many computers I needed. And the total cost of the project at that time was 6,000 Egyptian pounds, which is equivalent about $800 US. This is how I did the network. I went onto the internet and I saw how, oh, sorry, let me go back. So as you can see, can you put the mouse on this one, sorry?
You want to advance it? I think
The mouse,
you used
yeah.
this. Oh.
Yeah, this one is a mouse? Yeah, I think so. To bring it over, okay. No, okay, sure. Okay, so yeah, here we go. Yeah, here we go. Now it's right here. Okay, so I went onto the internet and I saw how to terminate an Ethernet cable. I bought one of those RJ things and I started doing the network. And as any IT person here in the room can tell me, it looks absolutely terrible. And I connected all the computers in the department, searched online for an open source PACS, and there we went. This is the first case I sent to the PACS system. Any radiologists here in the room? Raise of hands. Anyone in radiology? Yeah, here. Of course. Sorry, doctor. So this was my first case that I sent. This is the scout image, and this is a case of anterior mediastinal teratoma. And soon after, a month or two, they would call me up and tell me the system is not working. It's collapsing. Doctor tells me I can't write the report. I go back to drive back to the Asr Aini, and then I find out that the technician has removed the server power supply and used it to make some coffee. So I found out that this way, there is no way to maintain a hospital as large as Asr Aini by just an open source PACS and a one-man show. Later on, we started the electronic medical records project in Asr Aini. We made 2 tenders, one for picture archiving and communication system, and the other for hospital information system. Through the tender, the PACS system was awarded to Paxera, and the hospital information system was also awarded to an Egyptian company called DMS. And this is how my relation started with Paxera. Of course, I had a hardware problem, so there was a foundation at the time called the East Africa Aid Foundation. Through the help of many professors in my department, we were able to obtain a lot of hardware and diagnostic monitors that we use for the project. And this is how our data center looks today. The project had several hospitals to connect. We started off first with Al-Asr Aini, connecting several other hospitals that were across the Nile. And we divided projects into 3 different phases, and we're up to phase 2. And currently now, we're talking about a national level where we're going to connect all the hospitals in Egypt to one central PACS. And this is how it looks like today in our department. All the residents can automatically see the images on their computers and report them right away. Okay, I'm going to talk briefly about some of the AI tools available in the Paxera software. This is new in their software. If any radiologist knows in the room, it takes a lot of time for us to do some of the dirty work in radiology. The dirty work is counting the ribs, counting the lumbar vertebra if you have a tumor or a fracture or whatever, seeing how large the liver is, how large the spleen is, doing all these different segmentations for the organ is a process that's very time consuming. So through the use of AI, it can automatically provide you this information as soon as the image is sent to the PACS. This is an example of how it looks like when it counts the ribs for you and labels each rib and tells you which one it is. And on the right-hand side here, you can see that it provides information about each organ that it has segmented automatically. So it can tell you the density of the organ, whether there's a tumor within it, other information regarding the demographics of the patient. Other things are all stored onto the system. Okay, I need to play that video 1 second. Can you play the video, please? IT? Okay, let me try to do it myself.
Yeah, he's doing it.
He's doing it, okay. Here we go. Okay, so this is basically, if anyone is into AI, knows that one of the processes when developing any AI tool is segmenting the lesion of interest, or in this case, it's a tumor in the right kidney, a case of renal cell carcinoma. So this process is very time consuming because you have to go on each cut in the CT and manually or use thresholding to create a map for that tumor. So with use of advanced automatic segmentation tools like those available in Paxera, you can automatically, and as you saw in a matter of seconds, it can automatically segment the tumor for you. So later on, if there's a follow-up or if there's radiotherapy or chemotherapy or whatever, you can see the tumor's volume increasing or decreasing in size in the follow-ups of the patient. Okay, one of the new platforms that I've been really interested in seeing is called the ARC platform. So as most of you know, the total available softwares in AI are about 40 to 50 available tools in the market. And for a country like Egypt or maybe Rwanda to afford buying all these AI tools, it's very, very, very expensive. So one of the things that I like about the ARC platform and other platforms that do the same function is that you can develop your own AI tool. For example, you are interested in TB or you're interested in hepatocellular tumors. You can use the data sets you already have in your country to develop and segment and create these tools, AI tools, that you can later on use within your country and, or even sell to other institutions. So this is an example of how you can use this tool. You can segment automatically. This is the liver in a case of a cancer in the liver, where you can use these options like bounding box lesion segmentation that can automatically do it for you. And this algorithm is then saved and updated and trained so you can use later on. Okay, one of my other fields that I'm really interested in is neuro-oncology, and this is my work with another company called Neosoma. So how do we use AI in neuro-oncology? There are two methods, upstream and downstream. In the upstream, it can offer you things. It can, in the workflow, you can give priority to patients other than patients, like a patient with brain tumor. You can give him a priority through the AI to your workflow. You can use augmentation to improve signal-to-noise ratio, and you can specify specific protocols that are automatically embedded in the AI that can tell the technician, oh, this patient has a brain tumor, do the following sequences. And the downstream part is detection, classification, segmentation, and characterization and prediction. So first of all, you need to detect the tumor, classify which kind of tumor it is, segment it for later on for follow-up of this patient, and characterize it and say which grade it is, and predict the outcome and survival rate of the patient, all done through the AI. So I'm going to be talking more about the downstream part of it. This is a paper published in 2019. This is a multi-center study done in 3 hospitals. It's done about 1,600 MRIs from 3 different centers using mainly 3 Tesla scanners. It had a variety of tumors, lung, melanoma, breast, all metastasizing to the brain. As you can see, on the left-hand side is a ground truth done by a radiologist, and on the right-hand side is the output of the algorithm. So this study had a sensitivity of 96% and specificity of 99%. Anything above 90% in the AI is perfect. Okay, so this is a brief history of response assessment in neuroradiology. We call it the RANO criteria. Anyone working in radiology knows that right now when following up any tumor, we see what the gold standard is and we follow it. It started in 1977, where only CT scans were available. Then this was followed by the 1981 WHO criteria. This was followed by the 1990 McDonald's criteria. And then from 2000 to 2009, the RECIST criteria. But this never saw the light of day because it didn't address challenges in neuro-oncology. And then 2010 RANO criteria was developed, and this is the one we use still today. It added criteria for T2 flare, non-enhancing edema around the lesion, and it used 2D rather than 3D measurements. Okay, so what are the limitations of manual 2D RANO, the normal work we do in the radiology department? It tends to overestimate the tumor volume, and as you can see, if anyone is a radiologist in the room, if you measure the lesion on the top image, you will see that you will probably just measure the nodular enhancing component, and you'll probably not be able to rectify the marginal enhancing tumor. You will not be able to quantify it and measure it. So there is significant inter-rater and intra-rater variability, and there's no quantification of the non-enhancing flare volume, because as you can see in the bottom image, this is a flare image, the tumor is within the edema, so you can't really detect the volume of the edema and measure it. And because most radiologists don't have the time, you can only, or the criteria says just do 5 lesions. So if the patient has 9 or 10 lesions, you'll probably just measure 5 lesions and use those for follow-up. So it's a very time-consuming process. So this is the standard old way of doing things, measuring just the part of the tumor, the enhancing part solid that you see. And this is my work in neosoma. This is output of the algorithm. It can, as you can see in red, this is the edema. In green, this is the enhancing tumor volume. And in blue, this is the necrotic tissue in the tumor. And this is the only FDA-approved software that can do this. Okay, I know a lot of people in the room are not into radiology, so I'm going to explain briefly the concept of radiomics. So radiomics is a field of medical study that aims to extract a large number of quantitative features from medical images using data characterization algorithms. The data is assessed for improved decision support. It has the potential to discover disease characteristics that are difficult to identify by human vision alone. So I know this is very complicated. I'll try to simplify it more. Okay, so to my knowledge, these are 2 famous foods here. I don't know if I'm right or not, and please correct me if I pronounce them incorrectly. So on the left-hand side, this is called isombi, is that correct? On the right-hand side, this is isambaza, is that correct? Okay, thank you. Okay, so how many in the room can tell me that this is isombi and this is isambaza? How many in the room can tell me that this is it, just by looking at the image? Okay, that's great. How many of you can tell me what is the weight of this chicken? Sorry? Chicken leg, yes. What is the weight of it? How many kilograms is the chicken? That's impossible. Okay. For how long has that, what's the green vegetable called, sorry? That makes the zombie? The vegetable itself, what's it called? The leaf itself? Sorry? Time, sorry, I'm going to finish. So by using certain characteristics in the image, by segmenting the image, you can find out, and feeding a data set, you can find out certain information that cannot be seen by the naked eye. You can tell the weight of the chicken, you can tell how fresh that leaf is, maybe later on you can tell which farm it came from. And the same goes for the fish. By segmenting it and feeding data sets, you can tell the weight of the fish, you can tell how fresh it is from the eyes, and there are a lot of information that you can obtain from images that cannot be obtained by just the human vision alone. So I'm just going to be brief. So these are 2 papers. On the left-hand side, it shows that using improved glioma grading, convoluted neural networks, we can detect the grades of glioma just by looking at the MRI images. And on the right-hand side, this is another study showing that we can also, from the images alone, identify gene mutations in these tumors. This is a sign in radiology. They always teach us in radiology, never write the pathology. Even if you know what the pathology is, just say it's probably this, it's probably that. But this is a sign that is published that shows that for this specific tumor and this pattern of edema, through the power of radiomics, you can say with a 90% confidentiality that this is an astrocytoma, and more than that, you can say it's IDH mutant and the deletion, the code deletion, just by looking, or just by feeding the information into the AI. Thank you.
The pathologists in the house, you're not going to be replaced by radiomics, so don't worry. The physics behind what you see is a bit complex, so there's no way of summarizing it. And since it's about soft and hardwares, we are going to continue with Brian, who is going to give us more difficult computing, and he has got his own way of simplifying it. Please, next.
Great, thank you. I have a presentation up there somewhere. Make sure the volume's up. Volume, play.
Good morning. My name is George DePaul of Maven. I would like to speak with you for a few minutes before Brian gets on stage. You may be thinking he is coming up here to talk about how artificial intelligences, like me, will replace you. I promise you that he won't, and I will try my best not to. At this time, when there is so much talk about technologies such as artificial intelligence, robots, blockchain, the metaverse, and more, there is understandable concern that computers will take your jobs and that the humanity will be lost from care. I offer that the exact opposite will occur. I feel that over the past decades, the humanity has been missing from care, with the patient becoming lost along the way. These technologies may help find it again. Brian has had this belief for many years. In the future we see, there will be a greater number of more empathetic human caregivers, providing a higher standard of care, who cost far less to produce, and who are produced more quickly than the current medical education and training process allows. We believe that care will become more accessible, lower cost, of a higher quality, and be far more humane, and that the overall experience will be better for patients and caregivers. In the next half hour, Brian will tell you a story, his story, of healthcare's transformative journey that is now driven by the emergence of artificial intelligence, widespread high-speed connectivity, and immensely powerful computers, and the transition of healthcare that shall expand beyond the traditional hospital setting, with the majority of care being provided in outpatient and home settings. In this evolving landscape, the family medicine physician is poised to assume the central role as the genuine primary care provider. When I use the term primary, I am not merely referring to a gatekeeper directing patients to highly paid specialists. Instead, they will occupy the position of the central, chief, and principal provider of care, with other care providers playing a supporting role as secondary cast members. Furthermore, this transformation will extend to the domain of surgical procedures, with AI and robotic-assisted human technicians taking the lead. In this new era, hospitals will be smaller, characterized by higher acuity, and designed with a strong focus on information requirements, processes, and digitalization. Your history was marked by expensive hospitals, filled with expensive, difficult-to-access specialists, both of which will become things of the past. This paradigm shift will occur over decades and heralds a future in which the prominence of medical specialists and hospitals wanes, paving the way for family medicine and home-based care to assume a more prominent and compassionate role in healthcare provision. Now that I have opened this Pandora's box of thought, I will leave you with my colleague Brian to deal with the mess. I wish you a peaceful day and a wonderful Congress. Thank you.
Great. Thank you, George. I appreciate that mess that you've gotten me into. How do we,
Good morning.
no, how do we go to the next slide? It won't be a half hour, I promise you. This was, I spoke at the International Family Medicine Conference a few months ago, and George introduced me there. And I thought that some of what I presented there would be relative here, talking about bridging the gap, concerns about healthcare workforce availability, capacity, and also there's so much talk about AI, right? And I just wanted to kind of get us oriented a little bit. This is not necessarily an AI talk, and I'm not going to get into AI tools, and I'll try to keep it very short, but just to kind of orient us, where are we right now with all this AI stuff, which is really kind of nowhere compared to where we're going to be. So digitalization in general can help us solve problems. And as I pointed out yesterday, in healthcare globally, we have lots of problems. You know, there's lots of great things, but there are lots of problems. Hospitals are high risk, high reliability organizations. There is a global healthcare worker shortage. There's a chronic and critical worker shortage here. So it's a big problem. The cost globally is high, you know, on average 10% of GDP and increasing. That's not sustainable, and it doesn't need to be. And I'll briefly touch on the knowledge flood. I mean, this is just increasing exponentially. We can use digital solutions to solve these problems. I've had various successes over the years. I set up my first teleradiology platform for Dusit Medical Services in Thailand 20 years ago. You know, so I've been doing this digital stuff for a long time. I've set up telestroke programs. I did a teleeducation program in Ethiopia 10 years ago. Won a bunch of awards for different things. So I've done lots of digital things. Made lots of mistakes, probably more mistakes than successes. But in general, I've learned that technology can help, but it can only help if we use it. The one thing that's very true, there's been so much talk about digital health, right? But then if you actually try to find many people who have actually used it, who have actually implemented it, there's not that many. Over the last decade, over $100 billion has been invested in digital health with not much return on investment. So there's lots of talk. So that's why I say if we actually use it, lots of great tools, but if the regulators aren't on board, if the payers aren't on board, so this goes back to the systems discussion from yesterday. So there's lots of wonderful digital tools that you can use here if they're approved by your regulator, right? So it's a systems issue again. These are just repeating the problems from yesterday. The main one that we'll touch on is the flood of medical knowledge that you have to deal with now and will have to deal with going forward. But there is hope for technology. You know, I know we may feel that, well, it's just not happening and it's not happening fast enough. You know, you hear about all these cool new things coming out, but how come we don't have them? This is normal. It happened with the light bulb, right? The light bulb was invented in 1897. But imagine Thomas Edison walking into a house, right? What was the value of one light bulb in 1897? Does anyone know what the value of one light bulb would be in 1897? Any thoughts? Nothing. Walking into a house in 1897, where is the lamp that you're going to plug the light bulb into? Well, there's no lamps there. There's no wall socket. There's no power grid, right? So you got a light bulb, but there's no system to plug it into. It took another 40 years for the light and electricity to get to scale, right? And that's where we are with so many of these technologies, that they've been proven that they were viable, but it takes a while for systems to change. So technology, especially artificial intelligence, it will take years for it to go mainstream, regulations to change, people to accept it. So it's real, it's viable, but don't worry, you know, step by step, we'll get there. It takes time. We are with all technologies, we're in what's called the in-between period. So just to give you a quick orientation and some perspective on where we are with all this AI stuff compared to where we will be 5 years from now, 10 years from now. Okay, most of you have probably heard about, tried ChatGPT, the free version, the $20 a month version, whatever it is. That's like the tip of an enormous, enormous iceberg. It is basically nothing, yet it's so cool. I use it every day, right? And it's really powerful. There is so much beneath it that AI, just the AI models that we're developing now over the coming years will become thousands of times more powerful on our current computers. And this is a critical point that I'm making intentionally. So and even like things like ChatGPT, it's getting more powerful, and you're seeing Sonora, you're seeing all these things. They are becoming exponentially more powerful every month, every year. It's kind of crazy and hard. You're seeing all the different things people are presenting. This is on our normal classical computers. However, there's a whole other beast of a computer that's now becoming commercially viable, quantum computers. They are starting to become commercially viable, and within the next 5 to 10 years, there will be several cloud-based, which means you will all have access to them all over Rwanda, right? So anyone with a smartphone will have access to AI that's running on a quantum computer, which will just be completely insane, and I'll explain why. Because AI running on a quantum computer, the power of that, I can't even wrap my head around. I'll kind of try to put it in perspective. I wrote this for me to kind of get some orientation. AI today is a baby. It is an infant. I don't even know if it's this developed. You know, it may be a zygote. I mean, it is just nothing. It will grow up to become an army that will be 1,000 times stronger than it is today. I'm not exaggerating, maybe 10,000 times stronger on our current conventional classical computers. Now, imagine tossing this 1,000 times stronger army that's on our current computers, except we put them onto a quantum computer. A quantum computer will make the current AI models and future AI models 1 trillion times smarter. I cannot even wrap my head around it, and I'm not trying to. It's just a lot. A quantum computer, just to put things in perspective, in 3 minutes can run a simulation that it would take a current classical computer 10,000 years to produce. And where that's going to become really, really important, it will be able to fully simulate a human body, the entire biological systems, the biochemistry systems, as well as large molecules. You'll be able to, for clinical trials, you won't need humans. There's a point in the future where expensive, timely clinical trials will go away. Oh, by the way, that was me. So AI is going to go from baby to starship. When? I don't know. No idea. Not today, not tomorrow, 5 years, 10 years, 20 years, but eventually. It will transform everything. How we work, education, hospitals, the cost of care, outcomes, experiences. Will all of this stuff happen? Probably not. Not all of it. All, none. It'll probably be in between. Will AI replace you? Right, that's the question. Will AI replace you? No, AI is not going to replace you. AI will be used to do what it does best as a tool. And humans will do what we do best. You know, we've always done that. We've been augmented by technology for years. Agricultural machinery. That's a technological augmentation. You know, all of these are technologies that augmented us over the years, and everyone was concerned that we were going to be replaced by all of these. Well, we're still here. I'm still here, still clicking along, with all these things. AI, there are certain things that AI is just better at, sensing, pattern recognition, all of these things. AI, it's better than us at that, massively. And there's things that humans are good at, better, all of the things that I'm mentioning here. You don't need me to read to you. I'll give you all my presentations. So this is the big problem I wanted to touch on because it addresses so much of it, that there is an ocean. There is already an ocean of information out there, right? 30% of the world's data is from healthcare. We are only using 3% of that data. That's a problem right there. On top of that, medical knowledge is doubling every 73 days. How many doctors in the room? Don't be shy. How does it feel to know that you're all out of date? You're all dinosaurs, right? How many years since you graduated? Oh, I know you do the continuing medical education programs. And I know you're all learning a lot from that, aren't you? Right? With medical knowledge doubling every 73 days, it is simply impossible to keep up with it. I know we all try, we're trying our best, but it's, when baby AI grows up and has access to all the medical knowledge, all the diagnostic tests, all the treatment plans, all the outcomes everywhere, every specialty, the average frontline physician, the average GP, the average family medicine doctor will have access to everything. They will become a super specialist. Now, what will that do for access to care across the countries of Africa? It would be incredible. And the world. And it's not going to replace anyone. It's just going to give more people more access. It's fantastic. How will medical education need to change? For all the doctors in the room, all the stuff that you had to learn in medical school. Okay, I'll wrap it up. All right, medical education will need to change. Who is taught, what they're taught, how they're taught, all these things will need to change. And it's already felt anyway that medical education globally is broken. So I believe going forward, medical education will be far shorter because there will be less to learn. It'll be taught more effectively. It'll be lower cost. It'll be available to a larger segment of the population, which is important. Will result in significantly more healthcare workers and help to end the global healthcare worker shortage. There's more talk about hospitals, but we can have that at another time. Most of the care getting pushed out of the hospitals, only 10% remaining in the hospitals. I can skip through this stuff. Oh, yeah, this is the last thing I want to mention is how we currently design and build hospitals is wrong. And I mentioned that yesterday, and it definitely does not take into consideration anything digital. And I don't just mean the technology, I mean the hundreds of information systems within a hospital. The normal way we do it, someone has an idea, they do or don't do a feasibility study, they write up the size of the hospital, they design it, they build it, they equip it, they shove people into it, and then they start buying different technologies over the years. And this is one of the reasons we have these massive interoperability problems, is because over 5-10 years, all these different departments are buying these technologies, but they don't really care if they play well with each other, right? And then we start gradually developing systems and processes. This is all done after we've built the spaceship. It's wrong. It doesn't consider the information requirements, the system requirements, the technological requirements of the organization. Results in lots of problems. We've just developed a whole new digital by design methodology where from the very front end, we look at the information requirements of the organization, we look at all the system requirements of the organization, all the digital systems of the organization, and then and only then we designed an exoskeleton around this organization, which results in a far better organization. Just from design, it's already lean. From design, it's already compliant. It's already HIM 7 compliant. Even before you built it, you're compliant, and CHIME and everything. So it's a complete flipping the whole hospital design process around. You end up with a far better design process because it's digital. These are the first truly smart hospitals, not because they have cool technology in them. It has nothing to do, like everyone's been talking about smart hospitals for decades, and they're still stupid, right? These are smart hospitals because they're designed intelligently, taking into consideration all the systems, all the processes in the design process. I'm going to stop for now because I could just keep on going on and on and on. So, but thank you so much. Thanks.
Would you like to give him more applause, please? Very hard subject made easy. There's a lot that he can talk about, and there's a lot that he has done, as we heard from yesterday. Now, we have the knowledge, probably we have the understanding. How are we applying this into our systems beautification, systems transformation, and system application? We would like to hear from Silver Mugumya, an IT consultant and practitioner in the Ministry of Health. Kindly tell us the experience of Rwanda. Rwanda is a country that has heavily invested in the information technologies for the betterment of the way we teach, the way we treat, and generally the way we do care in our health facilities. Thank you.
Thank you. Thank you very much. I'm happy to be here. I have a presentation. Maybe while they are putting a presentation, I'm Silver, as they mentioned, and I'm currently Chief Digital Officer at the Ministry of Health, and I'm leading the healthcare digital transformation, as he mentioned. This is a journey, and I'm happy for the first and previous presenters. They mentioned about technologies, very good technologies, and mostly on the AI. I like how the AI is like assisting mostly in the bridging the gap for the healthcare workforce. And I think, as previously mentioned, the healthcare workforce is like an issue for the whole world. It's not only for Rwanda, it's for the whole world. So using technology, it's going to be assisting, and it's going to be supporting the few that we have, and it is going to be helping also the easing the patient journey. So what we are doing as Rwanda, so it's of course a journey that we embarked, and it's not going to be the journey that will be ending in 1 year. It has been there for 30 years, of course, 30 years from 94, and we are also still going far. We are still having a long journey to go. Is this working?
It's not working. I'm not sure where. I think the battery.
Point it up that way. I don't know where you pointed. Not the screen.
Not the screen. That way.
Maybe.
Ah, yeah. Okay.
So thank you very much. So yes, thank you very much. So for the global imperative, as I was mentioning, so this is common. It's not only particular for Rwanda. Of course, whatever we are doing in terms of technology, it's just enhancing the access. We need people to access the service. We need people to get the healthcare easily. So the improvement of infrastructure has been much on our priority as the government, and we have been investing much. I think here you all know that you can even be here. This is also an infrastructure that was also built for just supporting the access of the healthcare. Of course, we are trying to build the capabilities for our healthcare providers. We know that we need to support them with these digital tools. I will talk about very little digital tools that we are using. And then all what we are doing, it's for the awareness. We think, so people should not be coming to the hospital. Why do we need people to come to the hospital? I think we should make people not coming to the hospital. We should not be building many hospitals. We should not be training many physicians. Why don't we prevent people coming to the hospital? So this is awareness. So we are having many tools that we are trying to see if they can prevent people not just queuing at the hospital, but they can get well where they are home. And we are also trying to lower the per capita. So you understand, if you are bringing technology and the technology is increasing the cost of the service, so that's not a technology. I'm happy that the previous presenters, they mentioned about all the AI. So this means maybe if we use the technology, thank you for making this clear. So if we use the technology, so it will make us to even lower the cost of the service. So this is the situation. And I think it's not particular for Rwanda, where we are having different levels of healthcare, and at each healthcare level, we are capturing information, and this information is for the patient. This patient is a cancer patient. This patient is the same patient who is suffering from malaria, is the same patient who is suffering from maybe TB. So this same patient is coming to your level of healthcare. Maybe it's a clinic, or it's a primary, it's an advanced hospital. You are capturing information. You are taking his data. And then when he is going to the next, you can imagine, you can be like, have been treated like for 1 year. And when you go to another hospital, they're asking you, what's your name? And it is in the same country. So this is the issue that you will all meet, that they will always ask you, what's your name? How do you feel? And how did it started? I don't like this question. How did it start? You see, you have been treated like maybe on like the first level, second level, the third level. You are now at the fourth level, and they are asking you, how did it start? So you may not even be remembering how did it start. You can go to the next. So this is a problem. This is a problem, and this cannot make the AI work. So if the data are this way, so the AI will not help you. So there is something that we need to do, because the AI is good as the data, you gave to it, is good as huge data you are giving it to be trained on it. So you understand that we need firstly to get data together, and then we can now even train the AI, and we can use the AI. Let's try to go to the next. And this is the same. So this is the key challenge. So I explained it in a short. So you can imagine you don't feel well when you are at home. For us here in Rwanda, we are having, of course, several levels. Mostly if you need to, if you are home, so you have a nearby house. You need to have like a community health workers nearby. So you go and you tell him, I'm not feeling well, I have this and that. And they try to just treat you. They refer you to the next stage. They refer you to the next stage. It may happen. We have done this journey, and we have seen that sometimes a patient is passing through all of this journey. And at a given point, a doctor tells you, you first go to the insurance company, and they approve for you that I have to do for you this procedure. And this is a patient. This is someone ill. This is someone sick. that you are sending to the insurance headquarters. It's not even like a next door. It's an insurance headquarters to approve. So this is really a problem. And at the end of the day, we are not able to even know what happened to this patient. Maybe he started from us, he started from a community health worker, but at the end we don't know what happened. Did he die? Maybe he's still alive, maybe what? So we can't follow up, and this prevents a continuum of care. So this is a problem that we have seen as a country, which really makes patient suffering, and which cannot even allow us to benefit the advantage of using technology, because the data are scattered and this way. So I'm not going to be talking about this one because it's really cross countries and you know, it's the worldwide. We have computers at the first stage, and when you go to the next stage, you have papers, and then we go to another stage, so you have computers. It's a mixture. And I don't know, maybe the expert here will be telling me if the AI is going to help us in this mixture. I think, yes, it is possible, but we need also to be organized somehow. We need also to be structured somehow so that we can also benefit the advantages of using AI and other technologies. So after seeing this, as the country, as the health sector, we have said, okay, we have been solving problems with digital solutions, but let's try at least to go for digital transformation. Let's see the whole journey of the patient, and we base on the patient. So what we did, of course, this was like 4 years ago. We have seen that with the old paradigm, so someone was like, I'm not feeling well. It was too much reactive. It was too much disconnected. And it was like cycle. I'm not feeling well. I go to the doctor. I tell him the symptoms. He prescribes for me. I go home and it's done. So the doctor does not know what happened to me after that I left, and I don't have any communication with him at all. So we said, okay, so can we now create a new paradigm where we prevent people coming? We just at least receive the people that it happened that it's really needed to be at the hospital. Can we make these patients and doctors and physicians connected so that they can at least have that continuum of care, knowing what is happening to my patient after that he exited my hospital? What happened to him? Maybe he died after 2 seconds or 3 seconds, but you don't know. So disconnected and continuous care. So it's whatever we are implementing, whatever we are doing as a government in terms of digital, so it's what we are doing. Is it maybe the solution you are bringing? Is it like for prevention? Is it like for connected? And this is what we are doing also for cancer. We are having digital tools for screening. The most part is like we do screening and know how do you stand, maybe, because most of the cancer cases, we may find them like at the complicated stages. So the screening is much of the very important stage that we emphasize on. So after that, we have seen that we have problems. We said, okay, let's create a unified citizen health record. And when we get to this one, so the AI will apply. We can train it because we have a huge data. We have a very good data that we can try. And we also give chance to a patient to have an access to his medical record. If I may ask the public here, so who knows where his medical record is? Maybe if you go out, can you like bring me your medical record maybe in 1 hour, 2 hours? I don't think anyone can do that. Yeah. Thank you very much. So this way of like, you don't know where your medical record is, so you can't use it, you can't have a right on it. Of course, it is in one clinic A, clinic B, clinic C, and sometimes that clinic C has closed. You even don't know. So let's go to the next. So what we are creating is a single patient record at the national level so that each clinic at least can manage to synchronize the few data that can help, And whenever it closes, so it will not be a problem for you. But we are also creating the huge data for training our AI and other emerging technologies for also supporting the insight for the doctors and also for training them. So, sorry, I'm going back. So we are creating a longitudinal patient record, and this is a single source of truth. And I think if you can give me just in the next year, I think you will be starting seeing your medical record on your smartphone. So you will be able, at least, if I say, where is your medical record? You could even download them and you send it to me. If I'm like a doctor, you need a second opinion, so it will be very easy to get. So what we are creating, this is what I'm telling you, that next year you will be having this platform. So we first put together the data, so we need to give you now access on the data. And we will be telling you, the doctor called Silver has access to your medical record. Did you allow? And then you can sue. We have a data protection law. So now we are like bringing the transparency to the patient on what is happening to their medical record. Of course, all of this goes with the infrastructure. We have built Rwanda Health Cloud. As he mentioned, of course, you can't run on your computer the AI, so you need to have a cloud. So we have built Rwanda Health Cloud. All of this, they are the initiatives that the government started, but is continuous. And that we are also mobilizing stakeholders and investors to come be with us and build with us. And we know that soon, with this roadmap, we are getting there, and we are getting also to easier journey of the patient, giving the patient right to his medical record, having data. Because having data to analyze for the AI, it's very important. So this is the governance. You know that all of this depends on who is doing this, who is on top of this. So if you are not having the very good leadership and governance, so you will not get to anything. So I like to mention this because this is really something that made us to get to all of this. Thank you very much.
Thank you very much, Sylvain. Please give him another round of applause. There's a lot that we are doing that is being done, and thank you very much for the experience sharing. So now we've been talking about systems and systems governance. We would like to hear from our sister Rose about how the journey has been and how the journey is going to be much improved before we go to the applications. Thank you very much. Kindly, I know you have many...
Okay.
Yeah, you have many slides, but kindly make it short.
Okay, thank you. Good morning, everyone. I'm called Marie-Rose Kairangwa. I'm the country director for Japaigo Rwanda. I'm so honored to be here together with my brothers. As you can see, there is a balanced gender. It's a problem we need to really address seriously, but we will be there. So I'm so honored today to represent my wonderful colleagues at Japaigo who are working tirelessly in making sure that where women live should never determine if they live in family. So today, as my brother Dr. Emmanuel said, I'm going to try to share some perspective from the healthcare service delivery perspective. Of course, the collaboration with technology, with private sector, most importantly with Ministry of Health is key in that journey. I'm going to share with you who are we. Japaigo is a non-profit organization affiliated to Johns Hopkins University. We have been doing this business for more than 50 years. And currently we are working in different countries. We are partnering with ministries of health to enable government to ensure women and families have better access to quality healthcare services. We provide technical assistance, implementation, bringing in the country where we work global evidences to localized action with tools to adapt in the context where we are working. We partner with private sector, as other presenters said, because we need to evolve with where the world is going. Japaigo Rwanda, I'm going to present Japaigo Rwanda briefly. Since 2009 is where Japaigo started to work as an international NGO, but before, in 1989, Japaigo was working here supporting the University of Rwanda, especially to support gynecologists and obstetrician education. We are in different technical area. We are in HIV, but also maternal, child health, and newborn are our niche. We are supporting the ministry in different global health security, malaria research, and capacity building. We are partnering, we are using money especially for US government agencies, but also private foundation, Bill and Melinda Gates Foundation, Belgium Foundation, and different others. We are locally led, but also globally connected for global excellence. So on that specific topic that I'm really very happy to present on, that is really closer to my heart and passion, because those numbers we are seeing on the WHO, on different platforms about the number of people who are affected or dying from the cancer are not just numbers. They are human beings, they are our family relatives, they are ourselves. So what Japaigo is doing in making an impact on elimination of women cancers, especially I'm going to talk about two cancers. The first one is the cervical cancer. The second one is the breast cancer. For the cervical cancer, Japaigo is contributing to the global efforts, and as we all know that there are those targets set by globally by WHO, 90, 70, 90. What does it mean? It means that 90% of eligible and targeted girls should be vaccinated for human papilloma virus. And also for the outcome, 90% of screened women are 70% of women are screened, and in particular way HIV, women who are living on HIV and are on IRT, there is an emphasis on making sure that 90% of them are screened. And the other target is the 90% of women who screen positive receive treatment for cervical pre-cancer or cancer treatment. We are using different strategies and intervention in terms of prevention. There are primary intervention, that is vaccination, as I mentioned, but also how are we integrating those vaccination into adolescent girls and service. For secondary prevention, we collaborate with the Ministry of Health in different countries to make sure that HPV testing is included, and thermal ablation are expanded in service for people who are screened positive. We support service organization, we support transfer, we support mobilization to ensure that that long journey that our client had taken are smooth and facilitated. On other side, as others mentioned, we are partnering to ensure that we evolve. We use technology to facilitate patient navigation systems, to use artificial intelligence, to use also e-learning and virtual training for our healthcare providers to tackle also on gap of shortage of healthcare providers in terms of numbers and skills and quality. So the process innovation, we are now partnering with ministries of health to ensure that those self-care, self-testing is really implemented in a very good way, so that we facilitate and we avoid that overcrowding in the hospital. At policy level, we are supporting also to update guidelines, policies, and so on. There are key barriers that I'm not going to go into because most of my colleagues talked about that. On breast cancer, as most of you knows that breast cancer is really a huge problem. In Rwanda, I think it's the leading killer for cancer, and globally also it's really a problem. So how are we making impact? How are we contributing to do that? In country where we work, especially in Tanzania, Botswana, Mozambique, Ethiopia, we introduced and expanding programs that are promoting early detection and diagnosis of breast cancer, as well as the treatment. We are really mobilizing to facilitate, to make sure that people knows about those simple tips to make sure that early detection is done. We are building strong referral pathway, and also we are partnering with private to ensure that those technology are in place. So I think for digital health, I'm not going to talk about that. My brother presented on that, but also I would like to emphasize that we need to use those digital if we want really to tackle and quickly to go fast. Our women cancer purpose is to ensure that everyone is involved to really tackle the gap and bridge the gap, the care gap, in a different way. So I think our technical legacy in cancer is evolving with new introduction and approaches. So I'm going to pause here, and I'm
Thank you very
open
much,
to
my dear
anyone
sister.
who wants to hear more. You can go on our website and see what we are doing, and we can connect. Thank you so much.
Please give our sister another round of applause. She has respected time. So now, as we move from computing, from AI, from policies, guidelines, and standards, now we are going to see what some of these technological solutions are in helping us identify and probably care for the most pressing challenges today. Now, we would like to hear Naom. Yesterday he talked about the Ice Chewer. Today he's going to talk about another device that they created, innovated, and then now applying to help solve so many problems. Yes, please. guess this one can reach here.
Okay. Does he have a presentation? You can sit here.
Thank you very much.
You want to sit here for a presentation?
No, I don't have.
Okay.
Yes, I'm just gonna take a few minutes from your time to address a different topic from yesterday, as you mentioned, and Rose just mentioned it, and this is cervical cancer. I was associated not too long ago with a company called Mobile ODT, and Mobile ODT. No, no, oh, you don't. They developed and produced colposcope, and for many years they gathered a lot of data and managed to create an algorithm, an AI, that can identify, diagnostic cervical cancer, the abnormal cells. And as you know, cervical cancer is very tragic cancer because it's quite easy to identify and it's very easy to treat. In 20 minutes you can treat the patients and she can go away cancer-free if we are diagnostic on time. And this is already working today. We did projects in the Dominican, in Mexico, in Argentina, and we were trying to do something in Africa, and I'm gonna tell you a story that I think is relating to what Brian told us, that we have these great tools and solution and we are not using it. We worked with a large NGO from the US, and they purchased 90 units, 90 system of this mobile ODT with the mobile device with the AI to Lesotho. Lesotho is a small country with one of the largest rate of cervical cancer. And they purchased it 2.5 years ago, and it's still sitting in the warehouse, 90 devices. So first of all, I blame myself that I didn't make sure the whole ecosystem, the infrastructure is there in order to support this project, because you have to have people who knows how to work with these devices. And basically it came to solve the problems of not enough professionals. There are not enough colposcopists. And this AI, any midwives in a village can check the patients and can tell her, hey, you have abnormal cells. This is a great screening tools. Now, Mobile ODT, they have a partnership now with another company, Liger, that have a treatment tool with the pills. And the idea is to create the diagnostic and the treatment on the point of care. Because one of the issues is loss of follow-up. The patient is coming, she has cervical cancer, she gone, and it's hard to get her back to treat her. So I think this might be great for places like Rwanda that understand the needs to do this infrastructure and create the base for this kind of solutions. The NCI in the US, they create their own algorithm that's supposed to be out next year, and this will be OpenAI. So the idea, since the smartphones are so great today and the cameras are so sharp, so you will be able to download this app and use it on your own mobile. And I think that be revolutionized in this sense. I guess that's it. So I just wanted, to give you this story and make sure that it won't happen again. Thank you.
Thank you very much, Noam. See, this is so fantastic. I wish you could bring those devices to Rwanda, and as they sort themselves out, maybe you could buy them for them. So
They still exist in the warehouse, so I can.
Yeah, please do.
I'll speak with you about.
Thank you very much. So, and maybe since you are innovators, you could probably do some of the innovation here in Rwanda. You know, we have IRCAD Africa. We could have Ice Chua Africa. Thank you very much.
Thank you. I'll be loved to.
Yes. Can you please give him a round of applause again? Now, from that, we have talked since yesterday about screening, diagnosis, and a bit of treatment. And some other sessions are going to talk about other levels of management of cancer. But this time, we have one of the best in the region, Dr. Anup Kumar, who is the Director of Clinical Services, Clinical Support Services at Erecta that we have talked about. And he's going to talk to us about a wonderful solution that we could use. And you've heard about the burden of disease in terms of cancer on the continent. So tell us whether your solution is going to be like, we talk about family planning and we bring in IVF. Thank you very much.
Good morning, all. First of all, thank you very much. I'm very honored to be in front of you. Thank you very much for inviting us and giving us an opportunity to be here to give the different solutions from a company which pioneers in cancer care management. My colleague yesterday had clearly mentioned the different solutions which we are having for the radiation oncology for the body, as well as very specific for the gynecological indications. The product, and especially today's talk, is mainly on the innovation and technology and bridging the gap in cancer care in Africa. So that's where I thought I will put my product in the discussion panel over here. So why it's very important is that because we all talk about cancer management, and right now when I look into the Africa, because I'm based in Dubai, working for Electa for the past 3 decades, covering many countries. But what I notice is that many times in Africa, when we talk about the cancer management, it gets really focused, mainly maybe prostate or a breast cancer or maybe what you can call the gynecological indication. Definitely the prevalence of those indications are very, very high in Africa. It's true. But what is happening is that when we focus too much over there, we are slowly, or sometimes it's getting a little out of our mind, that with the new technologies, with all your systems in place with respect to the, what you can call the chemotherapy, with the brachytherapies coming up, and all the technologies, now you are giving at least some sort of screening as well as treatment to the patient. So now we are extending the life of the patient, which is a good thing. But we should not forget that when we extend the life of the patient, we are also increasing the chance of metastasis. And the metastasis could go all to the parts of the body, and definitely it goes to the brain as well. Because as we all know, most of the breast cancer as well as the gynecological cases, the metastasis chance to the brain is more than 40%. So this is where I thought I will talk about a product which is bringing a better accessibility, and we should also, when we bring a technology to the country or to a region, we should see the capability, what are the resource and how the resource will be capable to use it. So that's another thing. And in that case, what's more important is the ease of use. So with your all kind permission, let me just start my presentation. Thank you. So I'm just going to talk on updates on the Gamanef. I'm sorry, it's going the other way around. Can we just go back? Oh, okay. So it's a simplified and efficiency in cranial radiosurgery, because I'm talking about the indications of the cancers in the cranium, right? So what is going to happen is that this is a statistics from US which is telling that throughout the world, the stereotactic radiosurgery is going to be increasing in a very high number when you take about any hospital indications. The reason is that throughout the radiation oncology community and all, it's now understood that if you are so precise in giving the radiation only to the area where you want to give and spare the normal cells, you are reducing the toxicity. And in the brain, it's very important because every single millimeter in the brain is very important for our cognition management. Because if you irradiate the brain, you treat that treatment, but what happened? After 4 months, you will have a patient with a cognition declining. You will end up with the patients with absolutely confused memory fall, everything. So we need to take care about the quality of life while giving the good treatment as well. And let me just jump straight into a video, then I will come to the indication. Okay, so the product what I will be talking is Elekta Esprit, which is the most advanced integrated gamma knife from the company, which is mainly for the cranial indications. Yeah. I hope the audio will be working. Yes. Thank
The
you.
brain is the most precious organ in the human body, driving and managing the functions of the body, as well as being a repository for memories and personality. Treatment of diseases in the brain can significantly impact patients' quality of life. Leksell Gamma Knife radiosurgery is specifically designed to minimize that impact. Leksell Gamma Knife is providing a gentler, non-invasive alternative to traditional brain surgery and a more targeted approach than conventional radiotherapy. Leksell Gamma Knife uses 192 precisely focused beams of radiation to treat tumors or other abnormalities in the brain. The radiation beams are precisely focused to intersect at a single point called the isocenter. This is accurately positioned within the clinical target to achieve a maximum dose to the target while ensuring minimal dose to healthy tissues. Leksell Gamma Knife radiosurgery uses ionizing radiation to damage the diseased tissue beyond repair by disrupting the DNA structure in the cells. The type of radiation used in Leksell Gamma Knife is gamma radiation emitted from a radioactive isotope of cobalt known as cobalt-60. Because each cobalt source is very small, only 1 millimeter in diameter, and close to the target in the patient's brain, it provides superb precision for brain radiosurgery. Tungsten and lead shielding prevents unintended transmission of radiation and